Hi, everybody. This is Erica Mello, and welcome to our latest episode of Tough to Treat. And if you're listening to us live as these come out, you'll know that Susan and I are taking a bit of a break this summer. So we're re-releasing some of our more popular episodes, and also some of the episodes where we had a lot of questions on clinical questions, right? And so this is actually a patient of mine who. She basically came in to see me. I think I recorded this in 2018, 2019, and told me, you're my last resort. And when someone comes in to tell you that, immediately your nervous system goes on a high alert, right? You're like, oh my God, you're my last resort. Okay. Or what else? Or else, right? And this is basically what she said to me. And you'll listen in you can see in the description and below and throughout the entire episode. This girl had multiple injections. She had low back pain and injections, surgeries. She had an extensive history. For those of you who are new to the podcast, the power of the story. I spend probably 30 minutes getting someone's story because the narrative is so important. If you do not do that right, you will miss things. And also, if you do not do that right, it will make some of your evaluations less efficient, right? We want to prioritize when we're talking to the patient. After we hear their story, we prioritize, okay, what regions of the body am I interested in, right? Versus everything, right? So in this particular patient, she had multiple regions. Her issue was her low back, but she had multiple regions of the body and extensive history. So when you have somebody like that, you really have to think about, okay, well, what set her up and what kept her there. And if you were at CSM with Susan and myself back in February of this year, 2024, in the lecture I gave, I talk about what set them up in their injury history, what set them up and what kept them there. So when you have somebody like this, bear in mind, this was recorded some years ago now, but it was, you're going to get these stories today, right? So what set her up and what kept her there. And I hope you enjoy it. And for those of you who are new to the podcast, thank you for listening. And our website is toughtoTreat.com. Susan and I have two PDFs on there. I have a clinical pearl PDF. For those of you who are not on our email list, and Susan wrote a great piece on sleep and chronic pain, really important. Enjoy the episode. Hi, everybody. This is Erica Mello, and welcome to our latest episode of Tough to Treat. And if you're listening to us live as these come out, you'll know that Susan and I are taking a bit of a break this summer. So we're re-releasing some of our more popular episodes, and also some of the episodes where we had a lot of questions on clinical questions, right? And so this is actually a patient of mine who. She basically came in to see me. I think I recorded this in 2018, 2019, and told me, you're my last resort. And when someone comes in to tell you that, immediately your nervous system goes on a high alert, right? You're like, oh my God, you're my last resort. Okay. Or what else? Or else, right? And this is basically what she said to me. And you'll listen in you can see in the description and below and throughout the entire episode. This girl had multiple injections. She had low back pain and injections, surgeries. She had an extensive history. For those of you who are new to the podcast, the power of the story. I spend probably 30 minutes getting someone's story because the narrative is so important. If you do not do that right, you will miss things. And also, if you do not do that right, it will make some of your evaluations less efficient, right? We want to prioritize when we're talking to the patient. After we hear their story, we prioritize, okay, what regions of the body am I interested in, right? Versus everything, right? So in this particular patient, she had multiple regions. Her issue was her low back, but she had multiple regions of the body and extensive history. So when you have somebody like that, you really have to think about, okay, well, what set her up and what kept her there. And if you were at CSM with Susan and myself back in February of this year, 2024, in the lecture I gave, I talk about what set them up in their injury history, what set them up and what kept them there. So when you have somebody like this, bear in mind, this was recorded some years ago now, but it was, you're going to get these stories today, right? So what set her up and what kept her there. And I hope you enjoy it. And for those of you who are new to the podcast, thank you for listening. And our website is toughtotreat.com. Susan and I have 2 PDFs on there. I have a clinical pearl PDF. For those of you who are not on our email list, and Susan wrote a great piece on sleep and chronic pain, really important. Enjoy the episode. Hey everybody, this is Erica Mello and Susan Clinton, and you are listening to Tough to Treat. Let's get into this one. Yeah, let's get into her. She's a tough one. So I'm going to sort of break her down into little bits, and we can comment on the bits and pieces as we go. So this patient is a female, and she is 39 years old and came in to see me with complaints of right low back and groin pain. That was her major issue. What aggravated or sort of what exacerbated the symptoms were, well, many things. Standing and walking, obviously being vertical. Twisting, like standing and doing a body twist. And she said sitting was generally okay, except when she had to sit for long periods, like an airplane. She travels a bit for her job. So she's got an extensive history, so I'm going to go through that because I believe it's fairly relevant. So this started about 8 years ago. She called it, I actually put it in quotes on my eval, this has been an 8-year project, quote unquote. And she had an injury where she was hiking, and then she fell onto her right side. Didn't really fall down the mountain, but she actually probably fell onto some rocks and onto some of the hiking trails. She thought she may have fractured a rib on her right side. Doesn't really remember if that was the case. Mm-hmm. She thought she developed a scoliosis from that, et cetera, et cetera. 24 hours post-fall, she had nagging low back pain into the hip, into the right part of her ribs, more laterally, and down into her right hip. So that was sort of the onset. That's when it started. So she has been to, I'm just looking at this now, she's been to 5 physical therapists, a chiropractor, an acupuncturist, 2 orthopedists. She's had surgery for a labral tear 4 years ago, had PRP into her hip 1 year ago, times 3 injections. Prolozone into her quadratus lumborum 2 years ago, times 2. She had a nerve block and facet joint injections, and then 6 weeks before I saw her, she had a L4-5 steroid shot. I'm like, oh my God, OMG, all caps. I mean, Lord help us. And I just said, oh, okay. And her medical history, past medical history, with the exception of all of that, fractured her left ankle. She also had, which I thought was interesting, she had surgery 3 years ago. So this would be 5 years after her initial surgery for endometriosis. Oh. Exactly. So that's really basically what she told me.
Starting to get to some of the questions I was going to ask. So okay.
Yes. Then she also had a motor vehicle accident in 1993, where she had a concussion. Mm-hmm. And 3 years ago, she also had another MVA where she was thrown. So we've got this extensive medical history with multiple injections, multiple interventions, a fall, a couple concussions, endometrial surgery, and to top it all off, she had some addiction issues. Alcohol and drugs.
Okay.
And so this is what she said that, jokingly, I think, but, after she became sober, all these problems started, So that's what I had the first visit. And I looked at the history and I went, oh my God, no wonder this poor girl's frustrated, and she's had multiple injections. Multiple issues, interventions, and not better at all. Seriously. So I'm not even going to go into the objective yet. So based on the subjective, what do we think's going on with the subjective? I think it's always good exercise to do.
Yeah, it's a great one. And this is really a great one for us to kind of just, I hear this a lot from people. It's like, what do you do when you get something like this, a history like this? Where do you start? With this person, you have to start with what they're coming in for, because she's came to you because my back is hurting into my hip and it's been going into my groin and it's been going on for years.
Yep.
And it all seems to have started at this fall.
Yep.
And she definitely has problems with compression. Standing, walking, standing, twisting, and or long periods of time of sitting. So her system doesn't really like compression a lot.
No.
So you can kind of like begin to, think, okay, what happens if we decompress? Would that be something that could help? I would like to know if we did some decompression stuff, if that would, begin to alleviate some of this a little bit or make a difference. But what I really find so very, very, very interesting in this, and that was gonna be my first pinpoint until I heard about the motor vehicle accidents.
Yeah.
And the motor vehicle accidents are concerning for me because she did lose consciousness. She had concussions.
Yep.
So now I'm beginning to think about her trigeminal system is probably super wound up.
Yep.
And running the show.
Yep.
And whatever else was going on, this is amplifying it. She may not be having neck pain. She may not be having headaches. Is she having dizziness, headaches, anything like that?
No.
And what happens when her heart rate goes up? That would be some things I'd want to know. But no matter what else, even if she's not having those types of symptoms, it's probably amplifying the other symptoms that she was already having. Yes. And, so obviously the endometriosis is a problem, or she wouldn't have gone to surgery for it.
Yeah.
Is she having painful periods? What drove the, my question is what drove the surgery for the endo? And how much is that related to her back and growing pain? Because oftentimes you'll see, that viscerosomatic crosstalk going on there. And one can, and they could be two completely separate issues, but they could also be kind of confounding each other a bit. Something to kind of sort out. I don't know if you knew if she was on birth control pills or off, or
I'll tell you what
kind of treatment they gave her, because that could be a super factor here as well.
She was on antidepressants and Vicodin.
Okay.
That's pretty much it. The morning she was worse. She's had x-rays and MRIs. I was like, I don't even have them, to be honest. It was just at this point, it's not really going to be too helpful.
Right.
The endo, I didn't write it down, so I highlighted it though, and I think she was having obviously a lot of pain there. Mm-hmm. I'm still seeing her, and I certainly could go down that route. And because I looked at all of this, and I just said her nervous system's got to be so jacked up. It's not. Even though the endo was 5 years after the first MVA was way before, but the second MVA, she had the MVA and the endometriosis surgery 3 years ago. I don't know, the same time frame. She's getting the lumbar injections just six weeks prior to seeing me. You've had that many injections in your body. She is active. She rock climbs a lot. Okay. And she cycles. Mm-hmm. And she does a lot of yoga. So she does that really. The yoga does. There's certain positions in yoga which don't feel good for her. Mm-hmm. And I've been in contact with the yoga instructor, and we're trying to work out, because she's a really motivated yoga instructor. So we've been trying to do that. So just based on that, I would agree. The trigeminal system. Anything else that you gleaning from the subjective?
So, when you have these multiple accident people, it kind of makes me wonder if they're paying attention to what's going on around them.
Interesting.
So kind of, that's like, I find her comment that all of this happened after I got sober.
Yeah.
Except for that first car accident. And I'm wondering if that was the driver.
Yeah.
That led her to sobriety. There's definitely a past in here. Trying to figure out the first way in.
Yep.
You need to look at their back. You need to look at them move. No question about it. Mm-hmm. But my impression of going in to work with this person is to try to get this central nervous system to settle down.
Yeah.
Those things are glaring at me like crazy, mainly because there is the endo in there. Mm-hmm. And I'm wondering how much of, the triggers for her continued issues I'm just, kind of thinking, what if this isn't coming from the back? Just like you always like to say, like, what's the driver here?
Mm-hmm.
And, my bias, my confirmational bias is, wow, what's going on pelvic wise?
Mm-hmm. Yep.
Does she have pelvic muscles that are overactive?
Oh yeah, I'm sure.
Just crazy holding,
Mm-hmm.
so some great questions for her are going to be like, do you have, what's your pain like around your period? What
Mm-hmm.
happens around your menses before and
Mm-hmm.
after, during, because those are big endo things. And the other one is, do you have pain putting tampons in? A gynecological exam if they're not having sex. If they are having
Mm-hmm.
sex, are you having pain with sex?
Right.
You have it at certain times and not other times. So
Right.
is it worse, like closer to your period, or
Mm-hmm.
is it okay when you're further away? Have you changed the type, the position and things like that for intercourse? And if they're not having intercourse, again, you can use the gynecological exam. Does it
Yep.
painful when you go to see the gynecologist?
Right.
Have you, are you not using tampons, and why? Because sometimes for people it's preference. Other people it's like they don't realize that they've self-selected out because it hurts.
Right. Right.
So
Exactly.
those can be kind of ways to kind of tease out and say, what's going on inside the pelvis as well, because we're going to be taking a look outside, but it's nice to kind of know what might be rolling at
Mm-hmm.
inside as well.
Yep. So
Yeah.
I think doing, like, especially with somebody like this, you want to just take a step back and just take in and what they've told you. And I think
Yeah.
it's a good exercise for physical therapists to do. After the subjective, don't even look at your objective. Just
Mm-hmm.
after the subjective, just get a mental, like a hypothesis of what you think the issue is.
Yeah. And
So
this is a great time to also sit back and reflect with them.
yes. Yeah.
Tell me what you think is going on. How
Mm-hmm.
important do you think these motor vehicle accidents are to what's happening here? How,
Yes.
what was going on when you fell?
Mm-hmm.
What, kind of, if you can get them to like dig out some of the context around some of these things, that
Mm-hmm.
can help them kind of begin to start pulling some pieces together. But, just do it, like you said, just take that whole thing in and,
Mm-hmm.
spend some time with the reflection on it so that you really can get a real good sense of where this person is really, where are they getting hung up, and what do they really think is happening here.
Yeah, no, for sure. And she's a lovely person. And,
Mm-hmm.
no one had really done a thorough eval. So since standing was her main issue, well, not her main, it was one of them.
Mm-hmm.
I just looked at her in standing and
Yep.
she said, people told me not to twist. And I'm like, here we go again. The twisting thing's going to drive me nuts. I mean, she does yoga, for God's sake. She sits and does those, sitting rotational poses.
Mm-hmm.
So basically, without going into every little nitty gritty detail,
Mm-hmm.
because I actually did go into every little nitty gritty detail when I saw her bias in standing, ironically, was to get her weight on her right leg, which makes no sense, but she was significantly shifted in her pelvis to the right. So she was shifted to the right, her thorax was to the left, and her whole body was turned to the left. So a lot of weight bearing on the right leg. Her right foot was gripping, her navicular was just, her whole foot was very rigid. Her, she had no plantar glide in the foot at
Mm-hmm.
the talus. I kind of went up everywhere. Her hip, the femoral head was forward. Everything was just turned. Her right iliac crest was up. It was just, this was obvious. I mean, you look at her and this was an obvious postural issue, which she compensated for, and who knows if that's the way she was before. I doubt that's the way she was before her fall, but who knows.
How long ago was her fracture of her left ankle?
Good question. Let me see. Some years ago,
Uh-huh.
within that 8 year time frame.
Okay, so she had that fracture during this time.
I believe so.
Pain was
Yeah.
going on.
So,
That's very interesting because
and that was her left, though.
Yeah.
Yeah.
She's standing on the right, right?
Right. Yeah. Of course. Right.
You got to think about that. Wow.
Yep.
Maybe that's what started to drive her over.
To drive her over.
Mm-hmm.
But I mean, so when you see her pelvis is completely shifted. Her right iliac crest is up. I mean, she's compressed there.
Mm-hmm.
So, and she had issues with her neck and her head was a bit shifted. It's pretty much the usual you'll see with these types of patients. But the big issue was the weight bearing. So I said, let me just see how you do a body twist, because that was one of her issues as well. So actually, before I do that, I tried to shift her back onto her left leg, and I literally could not do it. It was just so hard to do. She was so committed to that right side. I just couldn't do it. I mean, I felt a huge block at her left hip. So what I ended up doing, I said, let me see how you do body twist. So she turned to the right, no problem. She turned to the left, and she couldn't turn to the left. You had the right adductor kicking, and that was an issue. And she sort of felt it on the right side of, right above by the PSISs. So I said, okay, that's, she just was not moving well. She wasn't standing well. She wasn't moving well. And so what I ended up doing in standing, just because this is how I started off with her, I just started making modifications to different body parts, and to see if that made her body twist better, because that was because she could forward bend no problem, she could back bend, she had a little bit of pain with back bending, but the twisting was the thing that was her meaningful issue. So I started, got the pelvis over. I applied some compression patterns. It's interesting because when I started doing some compression patterns and just getting her weight over on the left, made her worse. And I said, well, obviously compression is, an issue, which we know from her history, right? So it's nice to just sort of validate that. So I compressed the posterior, the anterior, did different oblique compressions, no better. As a matter of fact, worse.
Okay.
So then I said, let me look at her foot, because she's so committed to that right foot. So I ended up trying to, and we've talked about this in other podcasts, neutralizing her foot, and
just getting those little toes to let go.
Just to splay and yoga toes and make the big toe long and just relax. And her pelvis, she felt a bit better, but everything else was not better. Like in terms of, she was a little bit better subjectively and objectively the same. So it wasn't like, oh, this feels great. And as I'm going through this, I'm thinking, I don't think I'm actually going to get one issue in this. I don't think that I'm going to find one main issue as I'm doing this. So I ended up correcting the foot, doing the pelvic compression patterns, not really making a difference in her overall feeling of movement. Because I think at the beginning, you want to get them to feel the difference in the movement pattern. And she really wasn't. A little bit.
One thing that I do like, though, is that there was, when you got the foot to change, there was a difference. It wasn't a huge difference, but getting people that have been doing this for like 8 years, they're not able to see the grayscale. They only see the alarm bell, and they want that alarm bell off. And, getting them to like appreciate that, okay, it doesn't take away all of my symptoms, but it's different.
Correct.
Correct. And that, I think that's right there in the very beginning, like you said, there's so many things that need to be, that need to change for her. But you got to start somewhere, and man, that was a good one. Just get off the pelvis if it's not getting better. Quit doing it, and you shifted, it didn't get better. You compressed, it didn't get better. Like, so that's also ringing some intrapelvic bells for me.
Yes.
But, but the idea is like, go to the foot. The foot's right next to the pelvis on the homunculus,
Exactly.
And see what happens. And at least that didn't make it worse. That didn't ring alarm bells for her. It didn't make it worse. So it's like, okay, you can mess with the foot.
Yeah. So it's very interesting, because when I did correct the pelvis, as I said, it made everything worse. And I'm like, okay, I'm moving on. I'm not interested in the pelvis right now. I'm moving on. I don't care. I'm going elsewhere. So that's how I proceeded. Then, based on the history, my bias when I see somebody like this, I'm thinking dura, nervous system, cranium, something in the nervous system. So I ended up trying to shift the thorax over a little bit as well. That was my last intervention before I actually got her to sit. Because when I find that nothing I'm doing is making a difference, I have to do some nervous system stuff, because this is not about the foot or the pelvis. So I ended up sort of trying to get the thorax over the pelvis, just literally, manually, and she was doing her twist, and I felt this huge resistance again. I said, you know what? I'm moving on, because nothing I'm doing in standing is making a difference. It's making it worse. And it's making me think that there's just an underlying nervous system impairment here versus a joint, or a muscular imbalance. Could she have a muscular imbalance? Yes. I didn't think about
the intrapelvic issue at this point. But now that I'm talking to you, there could be some things in there as well. So, but I'll get to that in a second. So I just did some slumps. I sat her on the table, started doing some slumps, just slump testing. And it was reproducing her right-sided back pain, but it wasn't like flaring up a nerve or anything. I mean, after 8 years at this point, I don't think she's going to have an acute, nerve issue. So what I ended up doing, because she was sitting, I ended up literally just getting my hands on her head and just trying to bring some input to the nervous system. She had this shift in her head, and all I literally did was put my hands on her, just got the head over the thorax. I said, just do your slump test again for me. And she was like, oh, that feels a lot better. So for me, I said, interesting, because I didn't really do anything with the head in standing, because everything else, right, exactly. And I said to myself, okay, let's go down, let's get on the table, do an active straight leg raise, just whatever, do the active straight leg raise. I did the exact same thing with the head. I was sitting as well at the head of the table, and I just supported the head, and she literally was able to do the straight leg raise, no problem.
So you're decompressing through the head rather than decompressing through the thorax, through the pelvis.
Correct.
You just had to find where, again, remember we talked about in the very beginning, it's like compression is the enemy here.
Yep.
For hers, so to speak, because that's where she had her problems.
Right.
It was in compression, but you have to figure out how, and that's what I love. It's like, because that trigeminal system, just jumped out at me, those motor vehicle accidents and that upper cervical stuff. Mm-hmm. And then you went in and you got your hands on there, and it was, even if you all don't do a whole lot of stuff, just putting your hands in that area tells those muscles that they don't have to work so hard. Mm-hmm. That it's for some people, that can be it. And that, yeah. I love it, because it took her out of, her system could decompress itself, basically.
Yes.
It's what it did, is that just gave her a signal that it was like, I don't have to work so hard here, and now my system can change here. Right. And that's dramatic. That is dramatic. I love it.
So I think with her all her little shifts and head moves and rigid foot was, in a way, her nervous system trying to shorten itself at some point, depending on the task that she was doing, to make her feel better, or to try to make her feel better. So what was really, that was the eval. That eval took way over my hour, let me tell you. And for people who, my time management is always an issue with us, and I will tell you, I have an hour for evaluations. This took way more than the hour, and I didn't want to stop the flow. Basically, I didn't want to just stop at the hour and say I'll see you next week or whatever. I would have lost it. I needed to be sort of in the groove, so to speak. So after that was done, I was explaining basically what I thought. I thought there were some dural issues, some nervous system issues, and I said, I think you'll get better, Mm-hmm. And we made a plan to see each other the next week. She was referred by a friend of mine, and she called my friend up on the phone and said, you know what, this is the first time someone's ever given me hope. And I just lost it when I heard that, and I feel for people who've been through the ringer like this. Yeah, right?
So real quick, just because I think it's really, I want to know, is what did you send her home with?
Well, ironically, you're not going to believe what I did, because it's was the first thing that jumped out at me. I actually taped her foot. I just did, because that's the one intervention I did there, because her foot was, I know it was dural and neural, which is I gave her stuff for that, but I wanted to see if anything with the foot would make her better or worse. All I did was take the twist out of the foot with the tape. That was it. And then I sent her home with some dural glides, basically lying on her back, chin tuck, opposite arm leg, lower trunk rotation, lumps, anything, shorten one part of the nervous system, lengthen the other part. That's what I gave her. Plus I taped her foot. Then I gave her down dog with alternating knees, things like that.
Right. Things that she can do around her yoga. Perfect.
Correct. Mm-hmm. And that's basically what I did. It was just taking tension off one part of the nervous system and lengthening the other.
And this is where I'd love to get into that whole thing that I like to call grayscale, is that this person is already going to yoga. You
Mm.
know, you're taking something that she's already doing and she's in, I mean, that's her thing. She's in there. She's ready to go with that. And you're actually taking that and saying, let's do some variation around it.
Yeah.
Let's change it a little bit so that you don't have to feel like you got to like walk through and do things and, you know, make it, you know, just rigid. But you already started the idea that, you know, she could be a little bit more changeable in her yoga practice.
Exactly.
So that you could actually, you know, because she's going to go to yoga, you might as well do the downward dog and then do like these little things in here.
Mm-hmm.
You know, this is great to do right in the class. So it's meaningful. It's meaningful.
Yeah.
It's not just a series of exercises to just do. There was some meaning behind it too, which I love.
Exactly. So with her, you know, with people like her, any bit of movement, I wanted to send her home with something movement-wise. That's why I did some of the nervousness, the dural stuff, because it's obvious movement helps her. Rock climbing, cycling, yoga, she likes to move.
Right.
You know?
She's already had all those passive things. She's been injected.
I mean, injected
you
the
know,
wazoo and
she's been injected. You know, she's had things done to her. You're the first person who ever gave her permission to like, well, then let's find a different way to move.
Right. Exactly. I know, it's crazy. Actually, I'm just looking at my eval. So I take that back. I did treat her the first visit. I actually did some work on her foot a little bit and did some dural stuff. So basically, I sent her home with that.
Can't find that stuff and not do a little bit with it, right?
Yeah, exactly. So I did. I'm looking at her chart's like so much. It's crazy at this point. But I did some manual work on her. I taped her and then I sent her home with all that. And so she came back probably 3 weeks later. Not ideal. She, you know, had been everywhere and I think tapped out her financial resources in terms of getting physical therapy, which is sometimes tough when you're the last person they see. They're like, I have to come every so often. I'm like, fine. So she came in probably 3 weeks later, and ironically, she was feeling better, but her neck was sore. And I said, oh, that's interesting.
Doesn't surprise me a bit. Those
I know.
Finally starting to like do something different, and
I know.
They're gonna talk at you a little bit.
Yep. So the second, I mean, I'm going to go through quickly because I'm still treating her and and I've hit a bit of a plateau with her. So I want to get your input. So basically, so what I ended up doing similar, I did some cranial work with her. I did some just general movement, slumps, standing. I had her do assisted squatting, just with movement, doing one arm out. Just honestly, I was making it up like Tai Chi, to be honest. I was really, honestly, I had her just doing some squats with movement with the arms. I had her lying on her back. I had her doing some lateral lunges to get her off the right leg, more lateral to the side. Since she likes to rock climb, I ended up having her do some, so when she did her body twist, that really bothered her. So I had her extend her arms basically above her head. I said, do your body twist, then it'll decompress you. She had no problem. So I had her doing a lot of that, standing and rotating, standing and reaching, things like that.
Took her out of compression.
Right. Any like down dog, child's pose. I took the base postures and then I just added on to those. So, and I did that. And then ironically, this is what I did the third or fourth visit. I noticed she was really hyperextending her right knee. I'm like, why are you doing that? You know, you're hyperextending your knee, your right hip is up, and this is the biomechanical part coming back in me. But I just said, you know what? Because we were experimenting. I did an X taping on the back of her right knee to prevent genu recurvatum, to take the twist out of that part of her system. I just did. No reason. Honestly, no clinical reasoning behind that, except that I thought she needs to have part of her system unloaded. And that's why I did that. I don't have any other reason. It's just
the way that I look at that is that I don't have a problem with her, you know, standing on her right leg. What I have a problem with is her spending her entire time there.
Yes.
You know, it's become a dominant posture, and it's not one that's comfortable for her. It's one that actually drives her symptoms.
Yes.
So if you use a little tape, what you're basically doing with tape is you're putting sensory input into the system, and so the system is going to change out of that. You know, if you're tugging on the skin, they're going to move so that their skin isn't being tugged on. Why not? Give it a try. Did it help?
So it did help, actually. But I ended up also doing I like to do, with people like that who like to move, I like to do dynamic work. So I had a dynamic release work. I had her in a down dog and doing the alternating that she was doing at home. I had her do some breathing. I was trying to decompress the thorax, just getting some manual input while she was doing the movement pattern. I also did that with her on her back when, chin tuck, heel slides, arms out into sort of doing like a reverse fly, just doing movement while I was in her head or in the thorax, just doing some decompression. And I mean decompression, I'm literally just putting my hands and just giving her some input and decompressing, doing some cranial work while she was doing that to just get some more dynamic release. So, and that did help. So she was coming in maybe every 3 weeks now. So I would say the 4th or 5th visit, the work I've been doing with the movement patterning and the neck work had been helping. And she took a trip to California for work, so on the plane, she had no problem. So the sitting was better.
That's amazing.
All right. So so the sitting was good. That's where I'm at with her. So the sitting was good. And there came a period where I didn't see her for a month. So she started to do a lot more walking and a lot more standing. And that was starting to bother her a bit more. Okay. The sitting was good. She could fly, no problem. Sitting on a hard chair, though, still got her, but she said it was significantly better. I gave her, as what we call reset exercises to reset the system, like child's pose, down dog, her neural glides, her, all of her nervous system stuff. I gave her the down dog with the alternating legs, the child's pose, the slumps, lying on your back, the things we just talked about. Those, she didn't feel good. That's what she did. And she said those helped quite a bit. But I needed to get her, I needed to get that carried over to standing, like standing in a museum. We get a lot of people here in museums in New York. It's a big complaint. Okay. And I think the rock climbing is good for her. So I ended up just having her just do some basic triceps, we call them skull crushers. I wanted to see what load, if I added some load to the system, where her buckle point was. And she was losing the control in the head, even she was supine on the table, just doing some skull crushers. Her thorax was shifting, her head was moving, even with like a 3-pound weight. And I'm not saying that that's, indicative of a standing load, but
she was having trouble controlling that load.
She couldn't control it. So I sent her home with continuing what she was doing. And then I added some, just some skull crushers with some weight. And now we're at the point where she's feeling better. Walking is better, still gets her when she walks a long distance. The standing is still an issue. Okay. I had given her squats a little bit as well. This was the last visit, and I saw her just for basic squats, lunges, just to get her that movement pattern out of that right side. I explained to her that being on your right side is okay, but that can't be dominant. So you need to get off that side. So she's got it all. All right. So I'm right now, I'm at the point where she's feeling better, but the standing's still an issue. Okay. And I've done some work in the thorax, and because of this history, I just want your thoughts on, where maybe I'm missing something, or maybe I just need to take something up a notch. So, I'm really abbreviating what I've done, but the main issues I've mentioned. So.
Yeah. No, and it sounds like, the standing is the hardest piece, because that's where the neural tension system is going to be under the most load.
Yeah.
It just is. You can bend over and make it worse, but we're talking about something that a human needs to do for long periods of time. A lot of people have trouble with standing. They just really do. And depending upon the surfaces you stand on, the worse, the more unforgiving, the worse it is. I grew up in the Southwest, and we had people put that beautiful, beautiful Spanish tile all over their homes. And 10 years later, we watched them take it all up and put carpet down, because they couldn't take it. It was like too much.
Yeah.
So some of it could be that, but the other part, just her history here, this whole idea that whenever you started to decompress the system is when she could get better. And then you added movement, especially rotation. Seemed to really help her begin to make the changes. Plus she was doing active things and not passive things. And it takes a while to get that neural tension to really change. some of my thoughts are, I like the way that you actually decided, what happens if I start to load her and give her some loading exercises to do in supine? What would happen now if you did some of those loading exercises in sitting?
Yeah. Oh, great idea.
Where it's not standing, but she could be sitting and starting. And some of the ones I'm thinking of, I love the ones up above, with their arms up overhead.
Yep.
So like overhead presses and, maybe some tricep stuff overhead, things like that.
Yeah.
But one that is just hitting it for me for whatever reason is the latissimus dorsi, just the pull down.
Oh.
So that you start with your arms up and you're pulling down and breathing and, bringing in some different muscles and, something that might just trigger, her postural muscles to kind of maybe kick in a little bit more.
Yeah. Great.
And maybe even, a couple of like some crosses or some kind of, what do they call them? Chops, but just the movement, for some of those. But sitting, I think because you started her laying down loading, I think that sitting is good, but standing is still kind of a problem. So she could sit and do some loading. And I think that would be really cool to kind of see how she kind of works it out, and then eventually work up to doing some of that loading and standing, so that she's loading more than what she normally does. When you're standing, you're loading, but now what we're doing is loading standing. But I would start with it sitting, because you have to stair step it up a little bit, because her system is still sensitive.
Yeah, it's interesting. I'm just looking at my last note. She said, especially when she carries a backpack, that's when she feels it. And so
put everything in a rolling suitcase.
Yes. I know. Not fashionable, but necessary.
No, but you know what? You gotta get where you don't hurt. And this is a person who has to be on her feet. So
yeah, I know for sure.
They make some cute bags with rollers now.
They do. I know.
They really do.
They really do. In really pretty colors.
But sometimes it's stuff we don't think about. We just think about, okay, well, instead of carrying it in my arm on my right side, I'll just put it on my back.
Yeah.
And it's like, okay, but you just kind of traded one load for another.
Yes, I know. Exactly. It's because I'm looking at the last note again, and I rechecked her active straight leg raise, and the corrections in the past still worked. Decompression, the dural, the cranial, all the sort of modifying the head position, and all still worked. But I wrote down in my note last, it's very interesting, my little P in my SOAP was needs to increase load on weights on current exercises. And I do think those, as the sitting one, is great. I mean, that's overhead presses, lat pull down, skull crushers, wood choppers. That's all great, and I will do that because I have found that, especially with people who've had these persistent issues for so long, how you and how you progress the exercises. I think that was in a prior podcast that we did. That is key to getting these people better. And I mean key with all capitals. I found that in my own practice. You cannot be lazy when it comes to this stuff, but they have to be smart. So, they really do. And with somebody like this, the movement helped her, but now it's the standing, it's the carrying, it's the this, and that's the load issue.
Right. So she needs to learn how to load more in a way that doesn't, drive her symptoms, which is why I said start sitting.
Yeah,
sitting's better, and then progress up. She can progress to doing lat pull downs and standing. That might be one that, if I had to give her one to do in standing, that would be the one that I would go for, because it's going to be so you start up, she likes her arms up, and then you're pulling down, but as you're doing that, the latissimus is going to decompress her a little bit.
Yeah, totally.
So I mean, that would be a great one to, I think, to kind of like dip your toe in the water with a little bit, get some of that going. And I think that would be fantastic. But the thing that I would do with her is to either A, unload the backpack, or B, just get a rolling, a rolling thing that she can. And there's something about decompressing with that, too, a little bit. When you push down on that, it kind of helps you decompress a little bit. So if she's walking a lot for exercise, she could also grab a couple of Nordic sticks.
That's a great point.
And use those, because that can help a little decompression, while she's walking. If she's going to go out, you're in New York City, if she's going out to Central Park for a walk, for exercise, grab a couple of Nordic sticks and go.
Great idea.
It can be something she can try and see how that works with her. She may find that one works. She may find that she likes two. She may find that she doesn't like them at all. That's okay as well.
Yeah, it's a great idea. I know. That's an awesome idea because she likes to cycle, and cycling's good for her.
She should do all of those things.
She does. And the rock climbing, you're lifting your hands above your hair. No wonder she feels good.
Yep.
Right?
So the loading will help her performance in rock climbing.
Yeah.
Which is kind of, so you can kind of drive it that way. Like, this is going to make you a better rock climber. It's going to give you more power. So I have a couple of other thoughts that come into mind, mainly because we started off with this motor vehicle accident. Decompression of the cranium really helped. I would look to her, another way into the system to begin to change it again is through the cervico-ocular reflex.
Okay.
And I would go after her eyes.
Got it. Okay.
And get her moving those eyes and give her those VOR type exercises, where they're like, their eyes are like having a target hit, like a clock on a wall, and they're, target hitting their eyes on all of those things, or they're holding their eyes still and their head is moving to all of those targets, head shaking, making sure to get these eyes going and make sure, because oftentimes when people, if she's standing and she's hurting, she's probably freezing and compressing. The eyes can help bring her out of that. Yes. It's just another way into the system that will loosen her neck up and get her, and doing that. So some of the things that she does with rock climbing, she should probably do in standing. Do a few twists, do the head around, kind of don't stand, she's going to have to desensitize standing. So don't stand still for an hour. Don't do it. You always have to kind of be maybe doing a little shift and maybe a little move, but rotation, and the eyes can help, so she can kind of, like, as she's standing there, think, oh, I just need to kind of make my eyes go a little bit, turn my head, and then all of a sudden maybe her body will kind of come through and respond. And people like this too, if this is something she has to do for her job, or she's going to be recreationally in positions where she needs to stand a lot, is she needs to bring a change of shoes. There's nothing like changing your shoes on your feet to get your body to do something different.
That's great.
So that can be kind of a relief thing. It's kind of like when I do with cyclists who, like, I love to cycle, but after, 20 miles, perineal area just has had it. And it's like, bring a different a seat in your backpack on, and, or put it on your bike, so that when you stop and take a break, you can change seats. And go, and it's just a matter of, just giving them something else to sit on, like people like sit on a blanket, sit off a blanket, raise the chair up, lower the chair down. So I think, standing is a little bit more challenging to vary, but there's all these movements that you were doing with her. If she can kind of just remember that it's okay to sway and move and rotate and do some of those things. And then she's going to need to, like, time her breaks out, If you're before, if you can stand for 10 minutes and you're okay, that's great. Figure out how long you can stand. But you need to, like, stop. And, even if you can't get to a chair or a bench to sit on, you need to at least go find a wall to lean up against. To just give your system a rest a little bit. Maybe that's the time to, and then maybe do a little walking and then back to standing some. So all of those things kind of apply to there, which can be very helpful as well. But I just wanted to mention the eyes, because I feel like that you had some great stuff going with the system. And one of the things that can really help drive that trigeminal system down is really getting some great movement in the eyes again. They get so stuck, and so
I was going to say
about those all the time. And
no, we do. And that's
a great reminder. And then, of course, as you've been doing with her, breathing long exhales, giving her that, she's doing the yoga, just bring that yoga in. Maybe, a little cat-cow and standing, so, so the language that she can understand and speak it. I love the way that you were using the rock climbing stuff with her, because it feels good. So what in rock climbing can she do, in standing? What can that, how can you pull those things together and maybe see what she can come up with too?
Because I've been doing a lot of the unloaded stuff with her. I mean, a little of the squats and things, and just the lunges, but that's got her sitting better. But I really think that, I do think that the lapse in time between appointments is a factor, but you know what? You work with what you got. And
she can, and part
that's
of
the way
it
it goes.
Giving her system a chance to, her system isn't going to bounce back. I mean, this is 8 years. I think she's made remarkable progress
Yeah, I do too.
for the
Yeah.
sensitivity and stuff. And boy,
Yeah.
she's into it, right? She likes it.
Yeah.
But, she's got other factors in her life that are issues as well, and you have to deal with those. I mean,
Yeah.
she has to, maybe a little counseling would be a good thing for her. She's been on antidepressants and Vicodin for a while. There's other issues, obviously, in her life. And we all have other issues in our life. So, being able to do things a bit differently, and kind of, sometimes they can't come every week. They need to.
No. Yes.
And their hoping is I can only do this once every so often and make little changes, and that's fine.
Exactly. Because I was like, I don't need to stress you out financially. Come in every week, because that will definitely backfire.
Yep.
So I was like, you do what you can, and
And then, and then it doesn't improve as fast, and then there's that kind of like, well, PT didn't work.
Exactly.
Well, yeah, PT in a hurry isn't going to work, but PT
totally
is going to help. Yeah.
I love that, because people, come in 5 times, 3 times a week. I'm like, please, not with this type of patient. It just wasn't going to happen. And at the end of the day, I think, looking back on it now, it gave her nervous system a chance to sort of adjust in between visits. And I think the only thing is, I'm wondering if I should just, before we sign off here, should I revisit the endo surgery or ask her? I don't know. I mean, I don't know if I'm interested in the pelvis at this point, but I mean, no offense, but I don't know.
No, none taken. I mean, the only thing that would be of interest, well, there's so many things of interest, but if it's not of interest to her, then it's not, she just needs to know that if she's suffering in other ways that she may not have been talking to you about,
correct.
like,
Correct.
Sex doesn't hurt my back, but I don't like it because it hurts my vagina.
Got it.
Then she doesn't need to suffer. There's ways to help this. One of the things I would like to know is around the time when she's complaining of her back is kind of, does she ever associate that with menses or not?
Okay, I'll ask her.
And that would be of interest to know, and things like that. And the other thing is that just teaching her how to, you've looked at everything else. She probably is over gripping her abdominal muscles, and that may be part of what's going on with her in standing. Is that those muscles are over firing. They don't need to work as hard. Kind of teaching her to turn those guys off a little bit, or maybe even just massaging her belly. And
I've done that a little bit, actually. Yeah.
So those kinds of things are wonderful things that can help the other pieces. Because then you're getting the somatic visceral reflex going the opposite way. So just kind of massaging the belly, learning that. Look, when you're standing, just kind of take a look and see what her belly's doing in standing. Make sure she's just not over gripping. That could be maybe one of her, kind of another dominant type thing that might be going on that can be a changer for her.
Yeah, I think she's doing that, actually.
Yeah. So that would be the piece that I would start with. Does she have urgency frequency?
I don't believe so.
Yeah, that's usually a sign that pelvic floor is like over.
Yeah, no, I think I asked that. No, she doesn't. I mean, I'll ask that again.
Yeah, but the biggest thing is does she have pain with vaginal insertion? Because that can be desensitized, just like the sitting and the the other stuff could too. So you can send her off to somebody good she's interested in getting that feeling better as well, if it's a problem.
If it's a problem. Got it.
It may be one of those things she's not talking about because this is getting better, and it's like, well, this has been this way since I've been 12. She probably has no idea that could ever get better. Yeah.
I mean, she's had so many attacks on her nervous system over the years that my guess is that one of those answers to those questions is going to be yes. But I will ask her next time I see her.
Yeah. Just so that she can kind of complete the picture, because the nervous system is nervous system.
Yeah.
And it's that doesn't have to feel bad either. That everything is getting better. We'd love for that. If that's an issue for you, we'd love to help you get that better as well.
Yep.
It's all going to work along with everything I'm doing here. So
for sure.
Absolutely. What a great.
Yeah, this is interesting. I'm still treating her, so I will report back.
Yeah, I love it. I love the idea of getting together and just talking through it, and some ways to think about how to move forward.
Yeah, totally. Because I was so happy that she came. I mean, she's seen 5 PT. I mean, she's been everywhere, and for her to still continue to stay in the system here is a testament, because the friend that referred her is also a PT, but not in New York, obviously. So I really think that, if we can really work on getting these types of patients better, then, we'll advance our profession and, word of mouth. And I I think it's really important to stick with these patients. A lot of people would give up on her, but I think, people like her are becoming much more common in society, and they're accessing healthcare later and later, and their symptoms are going to become much more persistent. So I think it's great to talk about this stuff and get ideas for other patients. So I'll keep everybody posted, and that's that.
All right. Thank you, everybody, for listening.
Thanks, guys. See you next time.
Yep. And remember that you can leave us a review on iTunes. We'd love to hear from you. And if you haven't signed up for our emails, do so, because that's where we post information on mentoring and other little goodies that will be coming out as we move forward into our second year of podcasting.
Exactly. And we've got our Tough to Treat website, toughtotreat.com. Still a bit of a work in progress, but we've got signups, and feel free to go there as well. Okay.
All right.
Sounds
Thank
good.
you. Bye.
Bye.